morning. We're here at the Napa Valley Cardiology Conference. I have the pleasure of having Dr. Clyde Yancy with me this morning. Dr. Yancy is the Chief of Cardiovascular Services at Northwestern in Chicago. He has many different titles, which I won't go through for the purposes of this discussion, but he has a very unique perspective of not only really driving health care from the bedside, but also a vantage point of crafting healthcare policy for the country. We had a great discussion last night about the implications of the MACRA law, which is upon us. I thought we would continue those discussions personally with Dr. Yancy this morning. So Clyde, we had a fabulous 1 hour, hour and a half with Dr. Valentine yesterday. One of the questions that came out, one of the themes that came out in that discussion was, how do we actually get our physicians aligned around this act, which, as we showed by show of hands, most people don't even know is upon us. And we have a pretty short timeline of less than 6 months of preparation. In 2 years, it's here.
So, fascinating conversation last night. You completely nailed it. It was just really stunning to understand, first, the importance of the conversation, but more importantly, the naivete of otherwise very well-informed, very astute practitioners that are actively seeing patients and in practice. But the other thing that was very remarkable for me is that this is a state-of-the-art CME environment in which we're having these discussions. And we incorporate payment reform in a CME program that's looking at the advances in medical technology. Think about what that says. We have come fairly far now, where this is no longer the brochure on the table that you pick up on the way out. This is no longer the value-add auxiliary symposium. This is mainstream stuff with the understanding of the leadership that everyone needs to at least have the vernacular. You need to at least have heard it, but in this case, you need to act upon it.
Right.
So I really give you and the organizers a lot of credit for bringing this topic to the forefront. Now, you brought up the point of what are some of the real significant corollaries here. Let's be very clear, we're talking about MACRA. This is the Medicare Access and CHIPS Reauthorization payment reform model. Mm-hmm. And it is a lot to think about, a lot to say, and we need to remember what it really is. It is the replacement for the SGR.
Yeah.
All of us to a man said, we would like something different. And this is something different we got. The other big picture piece that we need to remember is that, yes, it is a replacement, but it's also a transition. This, if you will, is a inflection point in our development as practitioners that are more aware of the business in which we're involved. Because we are shifting definitively now from uniquely fee-for-service environments to pay-for-value compensation based on appropriateness of care. Right. And the way in which the customer, the patient, experiences that care. Radically different model. And like you said, I smile when we saw the graphic that it's on the train tracks and it's left the station. Yeah, it may be on the train and left the station, but this is a bullet train, guys. This is not a locomotive, it's a bullet train.
It's going.
Yeah, and then the third piece of this, when we deal with the big picture items, it replaces SGR, it introduces pay for value, if you will. But the third piece of this is that it very importantly uses a phenomenon known as behavioral economics. Mm-hmm. So trying to change behavior and using economic nudges. It's very interesting to recognize that as we have struggled with guideline implementation, it's very hard for people to digest doing things for the right reason. Mm-hmm. That seems to be an altruistic good that doesn't necessarily change behavior. It's very clear that when you withhold something from someone, right, that incites change.
Right.
But what happens when you reward people with something? So behavioral economics says maybe that works. So I think the best place to start is with these three top themes. It replaces the SGR. It introduces a brand new way of payment that we have to recognize. And it's using a business principle, behavioral economics, to get us to change.
Yeah. Well, it's interesting because I was thinking and reflecting this morning and this great symposium we had around heart failure management, and we saw all these novel therapies that are coming down the pike, not only from the pharmaceutical industry, but from the device industry and now the regenerative medicine space. and you think, medicine is right on the cusp of really breaking into an era of true therapeutic revolution. And at the same time, we've got this economic, I'll call it a burden for now, because we're being placed in a different economic environment where it's no longer we're just going to do all those things for everybody. We're going to have to collectively, as a physician community, self-manage it.
No, you're spot on. I mean, I don't ordinarily enjoy trite expressions, but in this case, it's not just the elephant in the room. There's a herd of bison in the room. And you really need to wake up, because you will get run over by this economic force that we're dealing with. But you also tapped into the best way for us to deal with this. This has happened to us time and time again. Innovation, science, research, discovery that changes the whole expression of disease in the natural history has always been our answer, and has always served us well. So that if we only do what we've been doing, this new system is going to be incredibly awkward, and there'll be more failures than there'll be successes. But as we continue the progression of bringing new therapies, new concepts, and breakthrough science to the table, we will radically change the disease processes that we've seen before, change healthcare utilization, consumption, all the things that are driving change. But I think it's important to share with you a thought that I had last evening that I hope you can appreciate. I had the unique responsibility, I won't quite call it a privilege, of being at the center of the healthcare reform debates in 2009 and 2010 as president of the Heart Association. And we took a deep breath and said, we support affordable care, understanding how many of our own constituency had great concerns about the Affordable Care Act. But the premise we used to support it was that it was a significant step forward in providing access. It was clearly an imperfect model, and we were relying on the ingenuity of the American process to modify, adapt, adjust as we go forward. And even though it's been a bumpy road, as time has gone forward, we've seen more people covered, we've seen costs become more manageable, we've seen quality get introduced, and you could make the argument that MACRA is not just a replacement for SGR, but the next extension of the Affordable Care Act. So I think that as there are some uncomfortable issues about MACRA, some specificities that everyone needs to be completely aware, it still is a process that through advocacy, through legislative efforts, we can improve this process going forward. We could never improve the SGR going forward. We could never, no matter what. This one we can actually do something about, and I hope that one of the places that we can improve it is that we, as the clinicians, as the clinician scientists, as the basic investigators, can come up with the evidence base that says what works and what doesn't work. Because if you're going to say, let's pay for value, then someone needs to define what's best care and what does value really mean for heart failure, for atrial fibrillation, for ACS. We're getting there. You could argue that in some disciplines we are sufficiently there that we can really sit at the table and say, okay, this is what best care looks like. And that's a reasonable way to do this.
Listen to you, it almost makes me excited about MACRA, but I'm kidding. No, but I do think the one thing, and I think you've touched on it exactly, is and the naivete expressed in the room last night around the fact that most people don't know that this is the physician payment law. It's really not so much hospital, and I think a lot of the docs are thinking that. That's not my problem, but it is their problem, and I think that's going to trigger, on the optimistic side of the equation, and we talked about that last night as well, I think that's going to trigger physician ingenuity to really kind of, and I see it amongst our own physicians already at Piedmont. I'm sure you do in your market and in your institution. Is that the docs are already starting to think about value-based medicine, and for instance, our nuclear, our stress test, nuclear MPI ordering is already down 25% just in the last year and a half. So you can kind of see. I think the goodness, if you would, of the side of the docs going, you know what, maybe they're right. We are wasting a lot of money.
So you could see this coming. And this is not a surprise. Healthcare reform started with the hospitals because, like you said, that is kind of an emotionless entity. It's an infrastructure And so they swallowed the first hit, the penalties, but you knew it was coming to the physician level. You knew that practitioners were ultimately going to have the quality of care and the business appropriate part of their care assessed. And we still wrestle with how much of that needs to be in the public domain, but you can't possibly believe that it won't ever be in the public domain. It will be. Yeah. And there are certain components of it that are already there. And so once everybody, not just your hospital, but your practice and your own personal return on the work that you've invested, once everybody has a skin in the game, that changes lots of behaviors. So what's going to be very interesting is to see what happens in this interface between physicians and patients when physicians are making decisions that patients feel might not be the way they want to be treated, but the physician has to respond to a number of different tugs. I love the commentary that came from Lars last evening when he said, we will ultimately only do what's best for the patient, no matter what. Right. And I think the head nodding in the room was my reassurance. Yeah. That no matter what the issues are, our DNA is solid. Yeah. And it says, I'm only going to do what's appropriate for this patient, and I want best outcomes for my patients. And I think if we can keep that principle very high and rely on experts to help us understand implementation and step up and identify areas where we think it can be made better, then probably we can swallow this pill. But this is one of those inevitabilities. We knew it was coming. We knew we were going to see a shift in how we were being rewarded. We knew that it would get to the physician level. It's here. Yeah.
Yeah, he was great. I think he even called it just maintaining our true north.
Yeah, I think
doing
that's
what's right. Patient first, doing what's right for the patient. Well, it's an exciting time, whether we want it to be or not, on all fronts, not just on the therapies and the changes in medicine, but in the responses that the docs are going to have in the way we deliver it. I have a son going to medical school, and as I've told him, you'll get paid in a different way, but it's still a great profession. It's a great job.
It's the greatest gig I've ever thought of, the greatest gig I've ever had. I think the one-word solution to change that's coming was brilliantly articulated by my good friend Bob Harrington. Yeah. So one-word answer, it's alignment. Yeah. And so that's a change in behavior for some of our physician colleagues because you're no longer at the top of the food chain. You're at the same level as everybody else, and you are aligned. Yeah. If you come together with alignment, wow, I think you can deal with all this stuff.
Build our systems.
Yeah, yeah.
Well, thank you for your time. Thank you for coming out. We appreciate your presence here at the meeting. Yeah, all right.